Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 297 of our pharmacotherapy series, which majors in heart failure. The next question reads, BJP is a 60-year-old man who presents to the emergency department with worsening dyspnea on exertion. He reports increased shortness of breath during the last week. His medical history includes hypertension, coronary artery disease, hyperlipidemia, and heart failure with an ejection fraction of 25%. His medications include metoprolol succinate 100 mg daily, enalapril 5 mg twice daily, furosemide 40 mg twice daily, aspirin 81 mg daily, and lovastatin 20 mg at bedtime. His vital signs on admission include BP 100 systolic 75 diastolic, a heart rate of 92 beats per minute, respiratory rate 18 breaths per minute, and O2 saturation 94% on room air. Laboratory values were BUN of 20 mg per deciliter and a serum creatinine of 1.4 mg per deciliter. Physical examination reveals pulmonary and peripheral edema and jugular venous pulse 10 cm. He is given 80 mg IV furosemide with minimal response. His dose was increased to 120 mg IV furosemide and he still does not respond adequately. Within the last 24 hours his serum creatinine has increased to 1.8 mg per deciliter and his BP is 92 systolic 70 diastolic. The decision is made to admit him to the coronary care unit where a pulmonary artery catheter, Swan-Ganz catheter, is placed, and the following hemodynamic variables are: pulmonary capillary wedge pressure of 21 mm of mercury, cardiac output of 3.64 liters per minute, cardiac index of 1.8 liters per minute per meter squared, systemic vascular resistance of 1489 dynes/second per centimeter power 5. In your opinion, is BJP a candidate for inotropic therapy? Let's begin by looking at dopamine and dobutamine. The hemodynamic profile of BJP is category 4, also known as cold and wet, because of hypoperfusion and congestion. According to the ACEIs guidelines, IV inotropic agents, such as dobutamine, dopamine, or milrinone, are indicated in symptomatic patients with reduced left ventricular ejection fraction, low cardiac output, or end-organ dysfunction, i.e., worsening renal function, and in patients who are intolerant to vasodilators. They are recommended for patients with cardiogenic shock or refractory symptoms, and may be used in patients requiring perioperative support after surgery or for those awaiting transplantation. Dobutamine is usually preferred in patients with low-output heart failure. Dobutamine improves cardiac output, decreases pulmonary capillary wedge pressure, and decreases total systemic vascular resistance with little effect on heart rate or systemic arterial pressure when compared with dopamine. We will now look at phosphodiesterase inhibitors using milrinone as an example. Although beta agonists, such as dobutamine, have been traditionally used in patients with acute decompensated heart failure, the phosphodiesterase inhibitor milrinone is an alternative to the catecholamines and vasodilators for the short-term parenteral treatment of severe congestive failure. This agent selectively inhibits phosphodiesterase 3, the cyclic adenosine monophosphate, cyclic AMP, specific cardiac phosphodiesterase. Enzyme inhibition results in increased cyclic AMP levels in myocardial cells and enhances contractility. The activity is not blocked by beta blockers. Phosphodiesterase inhibitors are also vasodilators. It has been suggested that at low doses they act more as unloading agents rather than as inotropic agents. Others refute this viewpoint. Their overall hemodynamic effect probably results from a combination of positive inotropic action plus preload and afterload reduction. Milrinone is structurally and pharmacologically similar to inamrinone, which is no longer used. Besides inhibiting phosphodiesterase, it also may increase calcium availability to myocardial muscle. It has both inotropic and vasodilating properties. Heart rate increase and myocardial consumption may be less with milrinone than with dobutamine. The half-life of milrinone is 1.5 to 2.5 hours, with renal clearance accounting for approximately 80% to 90% of total body elimination and is prolonged in patients with renal dysfunction. Although a loading dose of 50 micrograms per kilogram is in the product labeling, it is rarely given due to resulting hypotension. Maintenance infusions are typically between 0.2 and 0.75 micrograms per kilogram per minute. The infusion is adjusted according to hemodynamic and clinical responses and should be decreased in patients with renal insufficiency. The primary concern with milrinone is ventricular arrhythmias, reported in up to 12% of patients. Supraventricular arrhythmias, hypotension, headache, and chest pain also have been reported. Thrombocytopenia is rare. The outcomes of a prospective trial of intravenous milrinone for chronic heart failure, abbreviated as OPTIM-CHF trial, assessed the in-hospital management of 951 patients with acute heart failure exacerbation, with a mean left ventricular ejection fraction of 23%, but not in cardiogenic shock. In addition to standard diuretic and ACE inhibitor therapy, subjects were randomly assigned to receive either milrinone or placebo. The initial milrinone infusion rate was 0.5 microgram per kilogram per minute with no loading dose. The primary endpoint was total numbers of days hospitalized for cardiovascular causes from the time of the start of study drug infusion to day 60. No difference was found between milrinone and placebo, with mortality at 60 days, that is 10.3% with milrinone and 8.9% with placebo. Follow-up analysis categorized subjects as ischemic versus non-ischemic. Within the cohort of patients with ischemia, milrinone-treated patients tended to have worse outcomes than those treated with placebo. In contrast, non-ischemic patients had a trend toward better outcomes with milrinone than with placebo. From these data, it can be concluded that the benefits of milrinone in patients with acute exacerbations of heart failure are minimal and more likely to be seen in patients with a non-ischemic etiology of heart failure. Worse outcomes may be seen in patients with ischemic heart failure. However, short-term infusions of milrinone were not associated with excess mortality. Few trials have compared dobutamine to milrinone in acute decompensated heart failure. One small retrospective analysis evaluated patients admitted for acute decompensated heart failure, ejection fraction of less than 20%, who either received IV dobutamine or milrinone. Hemodynamic response, need for additional therapies, adverse effects, length of stay, and drug cost were evaluated. Patients were similar in clinical presentation, but the milrinone group had higher mean pulmonary arterial pressure. A greater percentage of patients received dobutamine, that is 81.7%, versus milrinone, that is 18.3%. Only 19% of patients were taking beta blockers before admission. Clinical outcomes were similar and there was no significant difference in the in-hospital mortality rate, adverse effects, ventilator use, or length of stay. More patients in the dobutamine group required nitroprusside to achieve optimal hemodynamic response. The study concluded that both drugs have comparable efficacy. Other factors to consider when deciding which inotropic agent should be used in acute decompensated heart failure are renal function, BP, and concomitant beta blocker use. Milrinone has a longer half-life than dobutamine, and accumulates in cases of renal dysfunction. Milrinone is also a vasodilator, which can limit its use in patients with hypotension. The concomitant use of beta blockers may antagonize the action of dobutamine. BJP has responded poorly to IV furosemide, his renal function has deteriorated, and his systolic BP is low. Patients with advanced heart failure and systemic hypoperfusion often will not tolerate vasodilator therapy. Inotropic agents may be necessary to maintain circulatory function in these patients. According to guidelines, IV inotropic drugs may be considered for patients who have symptomatic hypotension despite adequate filling pressure, who are unresponsive to diuretics and intolerant to vasodilators, or who have worsening renal function. Phosphodiesterase inhibitors are sometimes preferred over dobutamine for patients who are receiving concomitant beta blockers. For the above-mentioned reasons, BJP is a candidate for milrinone therapy. Patients should be on telemetry because milrinone has the potential to cause arrhythmias. Vital signs, serum creatinine, symptom relief, and urine output should be monitored. Once the patient's hemodynamic profile improves, milrinone should be discontinued, and oral furosemide therapy can be resumed. At discharge, the outpatient heart failure medications should be optimized. The next question reads, are there any indications for using repeated intermittent infusions of inotropic agents as part of a home care regimen? The long-term safety and efficacy of inotropic therapy is regarded with skepticism. There are few studies assessing intermittent, e.g., weekly, infusions of dobutamine or milrinone. Nearly all the data on this therapeutic approach are from open-label and uncontrolled trials that compare two inotropic agents without a placebo. It is thought that long-term therapy may be cardiotoxic. The only placebo-controlled trial of intermittent infusion of dobutamine was terminated because of excess mortality with dobutamine. Death occurred in 32% of patients treated with dobutamine versus 14% with placebo. Whether this was caused by progression of underlying heart disease, continued drug therapy, or was a cardiotoxic effect remains unknown. No corresponding data exist for milrinone, although a placebo-controlled trial with milrinone failed to support the routine use of IV milrinone as an adjunct to standard therapy in the treatment of patients hospitalized for an acute exacerbation of chronic heart failure. For this reason, the ACEI/AHA guidelines indicate that intermittent infusions of dobutamine and milrinone in the long-term treatment of heart failure, even in advanced stages, should be avoided. Chronic continuous infusions of dobutamine and milrinone are sometimes administered in patients with refractory heart failure as palliative therapy or in those awaiting transplant. The lowest dose possible should be administered. The Heart Failure Society of America identifies the limited treatment options in advanced heart failure and proposes patient-centered outcomes, survival versus quality of life, palliative and hospice care, to be incorporated into care plans. The next question reads, BJP was stabilized during the next several days and discharged home with furosemide 40 mg daily, enalapril 5 mg twice daily, metoprolol succinate 100 mg daily, aspirin 81 mg daily, and nitroglycerin 0.4 mg sublingual to be used as needed for chest pain. His ejection fraction is 23%. Laboratory values were normal. ECG monitoring during BJP's hospital stay showed normal sinus rhythm, with 15 to 20 asymptomatic premature ventricular contractions per hour. At that time, it was decided not to treat his arrhythmia other than with metoprolol because he was asymptomatic. For the next several months, he continued to have frequent premature ventricular contractions during follow-up examinations. It has now been 5 months and he is still having up to 12 to 15 premature ventricular contractions per hour. His exercise capacity is limited by shortness of breath after walking about a block despite having enalapril increased to 20 mg per day, metoprolol succinate to 200 mg per day, and adding digoxin 0.25 mg per day. The furosemide is at 40 mg per day because he has edema. A repeat echocardiogram shows an ejection fraction of 20%. In your opinion, is an antiarrhythmic agent indicated for BJP at this time? What is the agent of choice, and what dose should be given? Premature ventricular contractions and other arrhythmias are a common complication of left ventricular dysfunction and may be present regardless of whether the patient has had an MI. Approximately 50% to 70% of patients with heart failure have episodes of non-sustained ventricular tachycardia on ambulatory monitoring. This myocardial irritability may be a result of autonomic hyperactivity or ventricular remodeling. It is not clear whether these rhythm disturbances contribute to sudden death or simply reflect the underlying disease process. Recent studies suggest that bradyarrhythmia or electromechanical dissociation may be associated with sudden death in heart failure patients with non-ischemic cardiomyopathy. More importantly, suppression of ventricular ectopy in patients with heart failure has not been shown to lead to a reduction of sudden death in clinical trials. Neither prophylactic antiarrhythmic therapy nor treatment of asymptomatic premature ventricular contraction after an MI has been proven to improve outcome or survival. Because of concerns about the proarrhythmic effects of most Class 1A and Class 1C drugs, treatment with these agents is contraindicated. Amiodarone has value in patients with heart failure with arrhythmias because it has antiarrhythmic and coronary vasodilating effects as well as alpha and beta blocking properties. It may offer a dual benefit to reduce myocardial irritability and improve the hemodynamics of heart failure. In the Grupo de Estudio de la Sobrevida en la Insuficiencia Cardíaca en Argentina, abbreviated as GESICA, study, 516 patients with Class 2 to 4 heart failure symptoms with an average ejection fraction of 20%, and frequent premature ventricular contractions were randomly assigned to receive either standard treatment using diuretics, vasodilators, or digoxin, or a fixed dose of amiodarone plus standard treatment. The dose of amiodarone was 600 mg daily for 2 weeks, then 300 mg per day for at least 1 year. Fewer patients on amiodarone, that is 33.5%, died compared with those receiving standard treatment, that is 41.4%, a statistically significant difference. Similarly, the number of heart failure-related hospitalizations was reduced with amiodarone. Somewhat different outcomes were noted in the Veterans Administration (VA) Cooperative Survival Trial of Antiarrhythmic Therapy in Congestive Heart Failure, abbreviated as CHF START study. Entry criteria to this trial were similar to those in the GESICA study, with a primary indicator being more than 10 asymptomatic premature ventricular contractions per hour on 24-hour monitoring, but without sustained ventricular tachycardia. A higher dose of amiodarone was used, 800 mg for 2 weeks, then 400 mg per day for 1 year. The dose was reduced to 300 mg per day after the first year, with the average follow-up being 45 months. No difference was found between groups for either all-cause mortality or sickle cell disease. Ejection fraction improved more in the patients treated with amiodarone, rising from a baseline average of 24.9% to 33.7%. The corresponding change in the standard treatment group was from a baseline of 25.8% to 29.2% at follow-up. Despite the increase in ejection fraction, symptom scores did not differ between the two groups. Amiodarone does not have a negative effect on mortality as seen with some of the other antiarrhythmic agents. Other factors to consider are the potential for significant side effects with amiodarone and the drug interaction with digoxin leading to the potential for digoxin toxicity. The ACEI/AHA guidelines do not recommend routine ambulatory ECG monitoring to detect asymptomatic ventricular arrhythmias, and recommend against treatment if such arrhythmias are inadvertently detected. If symptomatic ventricular arrhythmias should arise or there is determined to be a high risk for sudden death, one of the following should be considered: a beta-blocking drug, amiodarone, or an ICD. Nearly all patients with heart failure should have a beta blocker as part of their regimen because these drugs reduce all-cause mortality, not just sudden death. BJP continued to have ectopy despite continued use of a beta blocker. Nonetheless, it is decided not to use amiodarone because he is asymptomatic. The next question reads, is BJP a candidate for an implantable cardioverter defibrillator implantation? Although amiodarone is the preferred antiarrhythmic agent in patients with heart failure with reduced ejection fraction to prevent recurrent atrial fibrillation and symptomatic ventricular arrhythmias, it has not improved survival. Ventricular arrhythmias are associated with a high frequency of sickle cell disease in patients with heart failure. Numerous trials have established the role of implantable cardioverter defibrillators in primary and secondary prevention of sickle cell disease. The earliest of the primary prevention trials was the Multi-Center Automatic Defibrillator Implantation Trial, abbreviated as MAD-IT. This study was terminated early because of the survival benefits seen in the implantable cardioverter defibrillator group compared with conventional therapy. There was no evidence that amiodarone, beta blockers, or any other antiarrhythmic therapy had a significant influence on the results. Unlike MAD-IT, the MAD-IT2 study enrolled patients with no documented arrhythmias but with previous ME and left ventricular ejection fraction less than 30%. Patients received either an implantable cardioverter defibrillator or conventional medical therapy. The primary endpoint was death from any cause. There was a 31% relative reduction in the risk of death and an absolute reduction of 6% in the implantable cardioverter defibrillator group. This was the first trial to show mortality benefits of implantable cardioverter defibrillators in patients with no documented history of abnormal heart rhythms. The Sudden Cardiac Death in Heart Failure Trial, abbreviated as SCD-HEFT, evaluated the efficacy of amiodarone in patients with left ventricular dysfunction, ejection fraction equal to or less than 35%. The patients, New York Heart Association Class 2 to 3, were receiving conventional therapy and randomly assigned to placebo, amiodarone, or an implantable cardioverter defibrillator. Amiodarone was no better than placebo, whereas implantable cardioverter defibrillator decreased mortality by 23% with a p-value equal to 0.007. A subgroup analysis showed that patients with Class 2 heart failure had a greater drop in mortality with implantable cardioverter defibrillator use than Class 3 patients, whereas amiodarone decreased survival in Class 3. The role of amiodarone in patients with New York Heart Association Class 3 needs to be further evaluated before it is routinely used in patients with left ventricular dysfunction. The ACEI/AHA guidelines recommend the use of implantable cardioverter defibrillators in patients after MI with reduced left ventricular ejection fraction and who have a history of ventricular arrhythmias. Implantable cardioverter defibrillators are also recommended for primary prevention in patients with non-ischemic cardiomyopathy and ischemic heart disease who have an left ventricular ejection fraction of 30% or less, those with New York Heart Association functional Class 2 or 3 symptoms while on optimal standard oral therapy, and patients who have reasonable expected survival with a good functional status of 1 or more years. Patients with ischemic heart disease should receive an implantable cardioverter defibrillator at least 40 days after MI. BJP is currently on optimal heart failure drug regimen, and his ejection fraction is 20%. According to guidelines, BJP would benefit from implantable cardioverter defibrillator implantation. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 298.